Okay, let's continue our discussion of the skeletal muscle, and now we're finally getting into the appendages. And we're going to start with the lower limb. Now, we're going to focus quite a bit of our efforts in terms of skeletal muscle in these appendages because this is really where the majority of your muscles are, particularly your bigger muscles, your more forceful, powerful contracting muscles, specifically in the lower limb. So we're going to split this particular discussion in terms of regions, and we're going to start with the femoral or the thigh region, so not only the anterior portion but also the posterior portion. Then we'll continue later with the leg and the foot region. So let's start with the anterior compartment of the thigh, and these are some of your strongest muscles of the whole body, right in this region, particularly your quadriceps femoris right here. This is a complex of 4 muscles, and we'll talk about this in a bit more detail, but there are other muscles in this region as well. Your iliopsoas, which is a very powerful flexor of the thigh, and your sartorius, which has the distinction of being your longest muscle in the body. All right, so it's going all the way from up in terms of the pelvic girdle all the way to your tibia, so a very long muscle. Now, the muscles of the anterior compartment of the thigh are going to play a role in terms of flexion of the hip, so think of moving your entire lower appendage anteriorly, and as well as extensors of the knee. So when you think of standing up straight, or if you are getting up from sitting, you are going to be extending your knees or straightening those out. And most of these muscles are going to be innervated by your femoral nerve, so very large nerve from the lumbosacral plexus. So let's actually look at some of these. So in this particular dissection, we're looking anteriorly. Let's start with the sartorius, and you can see here is your ilium. So remember, putting hands on your hips, we're feeling the iliac crest. So it's going to extend from there all the way, kind of wrap around to your tibia. So a very long expanse in terms of what it does. Now the sartorius is more of what we refer to as a synergist, meaning that it's not a very powerful contractor. It's going to assist other muscles and actions. And a lot of times you hear this muscle referred to as the Taylor's muscle. If you think of sitting crisscross, all the actions that occur to allow for you to sit in this position, the sartorius will play a small role in terms of that. Now let's focus a bit more on the quadriceps femoris, and this is this main complex of the anterior compartment. So all these muscles right here, like I said, and as the name would suggest, is going to be made up of 4 separately named muscles that kind of come together. Now, remember when we were talking about the osteology portion, we had that important sesamoid bone right in there. The patella is actually going to form within the tendon of your quadriceps femoris. So let's look at this in a bit more detail, these different components. You're going to have your vastus medialis, and as its name would indicate, this is the more medial one. Right in the middle and superficial is the rectus femoris. And then the largest component of your quadriceps femoris is the vastus lateralis. And obviously, as the name would indicate, it's lateral. This is the muscle that a lot of physical therapy, when you're conditioning the muscles in this region, a lot of those exercises focus on the vastus lateralis. So it can really help protect your knee joint in this region. Now, if you were to reflect your rectus femoris, then you can see that 4th component of the quadriceps, and that's your vastus intermedius. So in between the medialis and the lateralis and deep to the rectus femoris. So think about, we discussed it previously, but what do these muscles do when they contract? That's right, they're going to extend your knee joint, so straighten out the knee joint. One other muscle that I skipped, but we want to come back to it, is the iliopsoas. The iliopsoas is actually made up of the combination of 2 muscles. You have your psoas major and your iliacus muscle. And those two muscle bellies, they have a common tendon, and we refer to that as the iliopsoas. And you can't really see it very well in this visual. It's actually quite difficult to see unless you reflect a lot of the muscles right here. So it'd be deep to this, but here's your psoas major, and your iliacus is right in this region. And this is a very powerful muscle. This is the main flexor of the hip. So although you can't really see it in this particular dissection because it's deep, it's a very important muscle. Now let's move to the medial compartment of the thigh. So you can also see these typically in an anterior view as well, but they're going to be separated. They're going to have their own fascial compartment, and they're going to be more medially placed. And the main muscles here are your adductors, and you're going to have three adductor muscles. You'll have a longus, adductor brevis, and the big one and the more powerful one, adductor magnus. Additionally, the most medial muscle of the medial compartment is your gracilis muscle. This is not a very powerful muscle. It will play a synergistic role in terms of adduction. Now, I have right here a picture of the femur, obviously, and importantly, this is going to be a posterior view. And you see this line right on the shaft of the femur on the posterior view. This is your linea aspera. This is going to be the distal attachment for most of these muscles of the medial compartment. So if you think about contracting those, what are they going to do? Contract those adductor muscles? Well, obviously, they're going to adduct the thigh or put them back more into anatomical position. So, whereas the muscles of the anterior compartment are going to be innervated by the femoral nerve, the medial compartment is going to be innervated by that other large muscle of the lumbar plexus, the obturator nerve. So let's actually look at some of these muscles. So you can see in this visual, this is an anterior medial view. So here are those anterior compartment muscles, or the quadriceps femoris. And you can see this is obviously medial. Here is your adductor longus. Your adductor brevis would be deep to the longus, and then your gracilis is your most medial muscle right here. One muscle that you can't see in this view is your adductor magnus, and it is easier to see this muscle from a posterior view of the thigh, and you can see it right here. So very closely associated with those hamstring muscles in the posterior thigh. And actually, the adductor magnus has a component that acts in the same way as the hamstring muscles. Now, there are a few clinical considerations that I want you to think about in terms of the medial compartment. One, and this is a common theme for these muscles that are more synergistic, what we refer to as gracilis transplantation. So, if you were to remove components of the gracilis muscle, it's not going to play that big a role in terms of the actions of the thigh. So you can take portions of the muscle fibers there and transplant them to other areas, particularly the external anal sphincter. You can move muscle fibers from there, from the gracilis to this region if you have extreme damage there. And it won't affect the muscle or the actions of the medial compartment of the thigh. Additionally, when you hear the term groin pull, it's typically talking about some type of damage to the proximal attachments of the adductors. So let's think, where would these proximally attach if you're thinking about a groin pull? What's very closely associated osteologically? That's right, the pubis bone. All right, so your proximal attachment is going to be the pubis bone. If you have a tear there in terms of the tendons, if you have inflammation, this would be what we refer to as a groin pull. All right, now let's move. So we were talking anterior medial. Now we're going to move posteriorly, and we'll talk about some of the most powerful muscles. You had your quadriceps in the anterior, and then you'll have your gluteal muscles in the posterior. So let's start with the big one, as its name would indicate, your gluteus maximus. And this is really what's forming the bulk of your gluteal region. And you can see right here, it's the most superficial of your gluteal muscles and the largest. The fibers in this region are very coarse, very thick. It's very hard to dissect this region because the muscle fibers kind of intertwine with the deeper medius and minimus. Now, one thing I want you to note in this dissection, its main distal attachment is your IT band or your iliotibial tract. So that makes sense in terms of the main action of this muscle is going to be extension of the thigh. So if you think about climbing stairs, your gluteus maximus are really playing a big role in terms of that extension. So this is a superficial dissection here. If we were to reflect the gluteus maximus, then you're going to see the deeper gluteus medius and the gluteus minimus. And as their names would indicate, this is going to be the second largest and the third largest of the gluteal region. Now these muscles, unlike the gluteus maximus, they have a different insertion site, which is going to be the greater trochanter of the femur. So they have a separate attachment site, so obviously they're going to have a different action. And that's going to be abduction, or moving the hip joint or your thighs away from the midline, as well as play a role in terms of medial rotation of the thigh. Now, these two muscles are going to have a different innervation than the gluteus maximus, and we didn't talk about that before. Gluteus maximus is going to be innervated by your inferior gluteal nerve, whereas the medius and minimus are going to be innervated by the superior gluteal nerve. So let's actually look at these muscles here. So your gluteus maximus in this image has been reflected, and you can see how large and how thick these fibers are there. Just deep to that is your gluteus medius. You can see that piriformis that we discussed before, which has exited the greater sciatic notch. And in order to really see the gluteus minimus, you also have to reflect the medius, and you can see this is going to be right on the bone for the gluteus medius. So, one other thing I want to make sure you understand. So we talked about how the gluteus medius and minimus are innervated by the superior gluteal nerve. And they play a role in terms of abduction and medial rotation of the hip. But really the main role of the medius and minimus is to help your hips stay in line, okay? The sides of your hips from kind of falling when it contracts or when you're locomoting or walking. So if you have injury to your superior gluteal nerve, so say you have an injury to your right superior gluteal nerve, that can have implications in terms of how you walk. So in a typical walk, you're going to lift your left foot, and the right gluteus medius and minimus are going to contract and allow for your pelvic girdle to stay in line. But say your superior gluteal nerve on the right side has been injured, when you lift your left foot, this is not going to be able to contract. This right gluteus medius is not going to be able to contract, so you'll actually kind of tip your pelvic girdle and allow for you not to be able to pick up your foot as well as you typically would. So locomotion will be very much affected in some type of injury here. And this is referred to as your Trendelenburg sign, or a positive Trendelenburg sign. All right, let's go back to the piriformis. I told you that we'd get back to it, and here we are. So in this particular visual, the maximus and the medius have been cut. You can see your gluteus minimus here, and then this pear-shaped piriformis. Recall that it attached from the sacrum, and it's got to go all the way to the greater trochanter in order to play a role in terms of lateral rotation. Now, let me erase this right here so you can see a clean view of the piriformis. There's a very important nerve that's also exiting through the greater sciatic notch, inferior to the piriformis. And it is the main nerve of your lower limb, your sciatic nerve, and we've all heard of that. Sciatic nerve is the largest nerve of the body, and it's going to innervate all muscles of the lower limb except for those in the anterior and medial compartments of the thigh. So everything in the posterior thigh, as well as the lower limb or the leg and the foot. So let's talk about that posterior compartment of the thigh. So this is the last area that we're going to talk about in this particular presentation. And we refer to these muscles of the posterior compartment of the thigh as your hamstrings, and we've all heard of that before. And these are very rope-like muscles, so they're very strong, very powerful, particularly your biceps femoris muscle, and that's going to be the more lateral muscle. You also have your semitendinosus and your semimembranosus, and we'll actually look at those in a moment. Importantly, these muscles have a proximal attachment of the ischial tuberosity. So remember that ischial tuberosity in the posterior portion of the pelvic girdle is very built up because it has these strong muscles attaching here. These muscles are going to be innervated by that sciatic nerve that we just discussed, and specifically the tibial portion of the sciatic nerve. And you'll get into this in a bit more detail in the neuro portion, but I want to introduce the concept here because it's important. Sciatic nerve, largest nerve of your body, it's really made up of two components, the tibial and your common fibular nerve. So even though at this point in the posterior thigh, these two portions are combined, they're wrapped up in connective tissue together, it's really only these fibers of the tibial portion that are innervating the hamstrings. So lastly, think about your hamstring muscles. Think about what happens when you contract them. So you're flexing the leg. So if you think about flexing the knee, these are the main flexors of the knee, and they also will play a role in terms of extension of the thigh or of your hip joint. Now remember, what's the other main extender of the thigh? Is the gluteus maximus. So how are these different in terms of their roles? Well, the hamstrings are going to be tonically contracted when you're standing upright, when you're just standing, doing a lecture, working, etc. If you're not actively moving from flexion of the thigh to extension, that's more of the gluteus maximus. The hamstrings are more tonically contracted. So let's look at these. You have your, like we discussed before, your biceps femoris is kind of the powerhouse in terms of your hamstrings. And this is going to be the lateral of the hamstring muscles. And then you're going to have the kind of paired on the other side, semimembranosus and semitendinosus. And how you can tell these apart really come into their name. So the semitendinosus, and you can see right here, this is going to have a much longer tendon. It's going to extend to the tibia, like all the hamstring muscles do. So it has a very dominant tendon. And this is also going to be more superficial. So superficial to the membranosus, which is going to be deep. And really, if you're looking at a posterior view of the thigh, you're not going to see a dominant rope-like tendon for the semimembranosus, like you do with the semitendinosus. But really, in terms of that flexion of the knee, this biceps femoris is really the powerhouse there. So we see muscles here that are actually extending past the knee joint, so playing a role in terms of the actions of the knee joints. We're going to continue our discussion in the next presentation for those muscles that are actually within the leg that are going to affect both the ankle as well as the digits of the foot.